Dames en heren, ladies and gentlemen. Late onset disorders have an enormous impact on our society today. And that's particularly so for the disease that I have been studying now for almost 30 years, Alzheimer's disease. You probably know that there is no cure for Alzheimer's disease. And that's a devastating disease, both for the patients as well as their family and friends. You probably know that it's the most expensive disease in our healthcare system, and thus to our society. You probably know that by age 90, many of us will develop the disease. The Rotterdam study tells us that by age 90, 30% will have developed the disease up until that age. But did you know that the risk that you develop the disease is for at least 70% determined by your genetic makeup at birth already? And did you know that by now we have discovered more than 30 genetic variants that determine that risk, and that with that knowledge we can create a risk group of whom virtually everybody will have developed the disease already by age 80. That is the life expectancy of us in this room. But did you know that that very same set of genes, I can also use in the Rotterdam study to create a group of persons in whom 90% will be free of disease by age 90. Only 10% will develop the disease. Now, is there anyone in this audience that does not want to know what set of genes protect you from the disease till very late age 90? Is there anyone that doesn't want to know what these genes do to the body? What happens to the metabolism in the body of these people that make them live with a healthy brain up until old age? And is there anyone who wants to argue with me now that these people don't hold the key to the prevention of the disease? Ladies and gentlemen, in the past 3 years, we have teamed up in the Medical Delta to elucidate what happens in the body in these people that are protected and compared what happened to somebody who develops the disease because of their genetic makeup very early. And we have started to study this in the blood. That was the easiest. And using the data from the Rotterdam study, which has 25 years of follow-up, we could rapidly start measuring metabolites in the blood of those who were at high risk or at low risk of the disease. And we could follow in these people what happened to them 20 years before the disease onset, 10 years before the disease onset, 5 years, and around the onset of disease. Now, what makes the Medical Delta research so competitive? Well, within the setting of Rotterdam, we have not only data on the Rotterdam study at late age, but we also have available extensive studies starting already at age 0, in utero. And that is in the Generation R studies, where we just followed children from birth up until puberty now. And at the same time, we have the Erasmus-Rukven family study, in which we can study these same metabolites from middle age, around 18 till 70, over generations. And what we basically can do is not study the disease, of course, in a 1-year-old, but what we can study is the metabolite that is associated to the genes that increase or decrease the risk. And we can study whether in these newborn people the diet is relevant, or exposures or environmental factors. So we can do the epidemiological studies that learns us how to prevent the disease by lifestyle. But even more importantly, these metabolites are also biomarkers in clinical trials, and they are even more desperately needed, because in a clinical trial, it's by far easiest to stop this devastating disease at a stage where the devastating effect in the brain is still early. And at that time, there are no other markers. Imaging doesn't tell you anything. there's no hope for markers in the CSF, nor is there any hope for neuropsychological testing. What was our second mission? Our second mission was to study what happens in the brain of these persons. And for that we used stem cell technology. What we basically did, we started from the blood again, because we have a lot of that. And we basically reprogrammed some of our blood cells into induced stem cells, pluriform 1. And these can be differentiated back to brain cells. And you can study those on a chip. What makes us competitive here in the medical delta? Well, what has been very crucial here, that we can measure the metabolites at the nano level in very small quantities. The next speaker will show how. And we can do that at high throughput, not in 2 samples, but in thousands of samples, and that is very important. And then again, combining this technology with the deeply genotyped biobanks we have in Rotterdam means that we can study again what happens in the brain in the high-risk group and in the low-risk group. And that will give us targets which are very valuable. They're benchmarks by our genes. And they give you the targets that do something in the brain, and that should be targets for drug development at an early stage. The third mission, that was perhaps the most interesting one, in which we combined both and started making a brain on a chip. And basically what we did there is we just developed, using stem cell technology, the different cells in the brain. The neurons who do all the work, the oligodendrocytes that support them, and then the astrocytes that connect them to the blood vessels, very important. And the microglia, which are just protecting all the cells in the brain coming out of the blood. So we basically have developed this into a system now in which we use the phase guide technology of Leiden. That's also explained in the next talk. And we basically are now able to study in this model what happens to the metabolism in the blood, independently from what happens to the metabolism on the side of the brain and in the different brain cells. That gives us something unique in hand, but what is also possible using this system, that in the setting of a chip, we can do clinical tests. We can give the system medication. New medication or old medication. And we can do that using a model that is based on very different combinations of genes. And that will be very valuable. That will give us more precise medication, more personalized one, and more powerful tests to evaluate that. Ladies and gentlemen, in the past 3 years, we have made a toolbox. We have received a lot of support to do that, nationally, internationally, to prevent Alzheimer's disease. And basically we're coupling the genes, what happens in the body, and try to see how we can prevent the disease. I hope you agree with me that in these metabolites are the key to prevention, and that basically we will have a toolbox that aims to prevent the disease and keep the brains of the population healthy up until very old age. So that is important. That is important for future patients. That is important for their families. But it's definitely important for our society, in which the life expectancy is ever growing. Now, will that work only in Alzheimer? No, we're already working on other age-related diseases, and we know for many a lot of genes that are determining their risk: stroke, glaucoma, diabetes. And the mission of the Chair in Translational Epidemiology, I and my colleague Thomas Hankemeyer will work on, is to work with academic and commercial partners to improve our understanding of healthy aging and prevention of diseases in the aging population. Ik heb gezegd